Good evening. Tonight, we delve into a pivotal question at the intersection of mental health care and professional practice. Should psychologists be permitted to prescribe medication? This issue is not merely academic. It carries significant implications for patient access to treatment, the scope of psychological practice, and the very structure of mental health services. It's a topic that sparks considerable debate among healthcare professionals, policymakers, and the public alike, touching on deeply held views about training, safety, and the best pathways to care. To explore this complex subject, we are joined by two distinguished experts. Dr. Ben Carter is a clinical psychologist who advocates for extending prescribing rights to suitably qualified psychologists, and Dr. Lena Petrova, a psychiatrist who holds reservations about such a move and will argue against it. Welcome to you both.
Thank you, Dr. Hayes. I believe it's crucial that we seriously consider expanding prescribing rights to appropriately trained psychologists. My primary argument centers on a pressing reality: the significant gap in access to mental health care, especially for medication management. Many individuals, particularly those in rural communities or underserved urban areas, face lengthy waiting lists or prohibitive travel distances to see a psychiatrist. This delay in care can exacerbate conditions and prolong suffering unnecessarily. Allowing qualified psychologists to prescribe could substantially alleviate this bottleneck. Furthermore, this move would foster a truly integrated care model. Imagine a patient receiving therapy and medication management from the same trusted professional. This eliminates the often disjointed experience of shuttling between a therapist and a prescriber, leading to more holistic, coordinated, and ultimately more effective patient care. It ensures that medication decisions are made in concert with a deep understanding of the patient's psychological state and therapeutic progress. And let me be clear, we are not advocating for psychologists to prescribe without the necessary expertise. The proposal involves rigorous, specialized training in psychopharmacology. This would include comprehensive coursework, supervised clinical experience, and examinations to ensure competency in safely and effectively managing psychotropic medications. This isn't about lowering standards. It's about expanding the pool of qualified professionals to meet an overwhelming need.
Dr. Hayes, thank you. While I share Dr. Carter's concern for accessible mental health care, I must strongly oppose the proposal to grant prescribing authority to psychologists. My opposition is rooted in a fundamental concern for patient safety, which hinges on the comprehensive medical training that physicians, specifically psychiatrists, undertake. Psychotropic medications are not simple remedies. They are powerful substances with complex mechanisms of action, a wide range of potential side effects, and intricate interactions with other drugs and bodily systems. Managing these medications safely requires a deep understanding of human physiology, pharmacology, and pathology, knowledge that is foundational to medical school and psychiatric residency, but not to psychology training. A critical aspect of psychiatric practice is the ability to differentiate between a primary psychiatric disorder and a psychological manifestation of an underlying physical illness. Many medical conditions, such as thyroid disorders, neurological problems, or even infections, can present with symptoms like depression or anxiety. Psychiatrists are trained to conduct thorough medical evaluations to rule these out. I fear that without this extensive medical background, psychologists might inadvertently misdiagnose or, more critically, overlook serious medical conditions, leading to inappropriate treatment and potential harm. Furthermore, rather than integrating care, this could paradoxically lead to greater fragmentation or the establishment of a two-tiered system where the quality of psychopharmacological care may vary significantly. Patient safety must always be our paramount concern, and I believe this proposal, however well-intentioned, carries unacceptable risks.
Dr. Petrova raises valid points about training, but I must reiterate that the models for prescribing psychologists are built upon extensive, specialized education in psychopharmacology. This isn't a weekend course. It's typically a master's level program post-doctorate, including hundreds of hours of didactic learning and, crucially, supervised clinical experience, specifically in medication management. Regarding the concern about overlooking medical conditions, this is a serious consideration addressed directly in proposed frameworks. These frameworks mandate close collaboration with the patient's primary care physician and, when necessary, other medical specialists. Prescribing psychologists would work as part of a healthcare team, ensuring that comprehensive physical health assessments are always conducted, often by the PCP, before psychotropic medication is considered for psychological symptoms. Let's not forget, clinical psychologists possess a profound understanding of mental health disorders, psychopathology, and behavioral science, often more in-depth in these specific areas than many general medical practitioners. This existing expertise forms a strong foundation upon which specialized psychopharmacology training can build, making them exceptionally well-suited to manage these medications responsibly within a collaborative framework.
While I acknowledge the intention for additional training, Dr. Carter, it's essential to recognize the profound difference in scale and scope compared to medical education. Medical school and a subsequent psychiatric residency involve years of immersive training, covering the entirety of human physiology, pathology, pharmacology across all organ systems, and complex differential diagnosis. A specialized course in psychopharmacology, however rigorous, simply cannot replicate that breadth and depth of understanding of the human body and its potential ailments. Can such training truly equip someone to confidently distinguish, for example, early-onset dementia presenting as depression from a primary depressive disorder, or a subtle neurological issue mimicking anxiety? These are nuanced diagnostic challenges that often require a comprehensive medical perspective that extends far beyond psychotropic medications themselves. My concern extends to what is often termed scope creep. If psychologists begin prescribing, where does the boundary lie? What other complex medical tasks might follow? This isn't about protecting turf. It's about protecting patients by ensuring that the most complex tasks are handled by those with the most comprehensive and appropriate medical training. Diluting that specialized medical expertise, I fear, could inadvertently lead to compromises in patient safety, despite the best intentions.
Dr. Carter, Dr. Petrova has emphasized the critical skill of differentiating primary psychiatric disorders from medical conditions with psychological symptoms, a skill honed during extensive psychiatric training. How would your proposed model for prescribing psychologists concretely ensure patient safety when faced with these complex diagnostic challenges? To prevent misdiagnosis or delayed treatment of underlying physical illnesses?
That's a crucial question, Dr. Hayes, and patient safety is paramount in any proposed model. Firstly, the specialized psychopharmacology training explicitly includes modules on medical screening and differential diagnoses within the psychologist's scope. This means training psychologists to recognize red flags that suggest an underlying medical cause and to understand when immediate medical referral is necessary. Secondly, and this is vital, the model mandates a collaborative relationship with primary care physicians, as I mentioned, before initiating psychotropic medication for many conditions, particularly new onset or atypical presentations. A recent physical examination and appropriate lab work, coordinated with or performed by the PCP, would be standard protocol. The psychologist's role is not to become a primary care physician, but to be an expert in mental health who can work effectively within a medical team, utilizing medical consultations appropriately. They would be trained to understand the limits of their scope and when to refer to psychiatrists for more complex cases, or when medical comorbidities are significant. It's about safe, responsible practice within defined boundaries.
Dr. Petrova, we know that in some settings, such as within the U.S. military, the Indian Health Service, and a few states like New Mexico and Louisiana, psychologists have had prescribing privileges for a number of years. From your perspective, what is your assessment of the patient outcomes and safety data that has emerged from these existing practices? Do these examples alleviate or confirm your concerns?
Dr. Hayes, it's true that these programs exist, and the data emerging from them is often cited by proponents. However, I believe a cautious interpretation is warranted. Firstly, many of these settings, particularly the military and Indian Health Service, are highly structured environments with integrated healthcare systems and close supervision, which may not be easily replicable in broader civilian practice. The psychologists prescribing there often work in very close collaboration with physicians, which is a positive aspect, but again, this level of integration isn't universal. While some studies suggest comparable outcomes for specific conditions and no widespread safety crises, other analyses and anecdotal reports continue to raise questions about the thoroughness of medical workups and the management of complex cases or side effects. Furthermore, the long-term data across diverse populations and less controlled settings is still relatively limited. We need to be careful about extrapolating findings from these specific contexts to a general population model. My concern remains that while these programs might function adequately in specific, controlled circumstances, they don't fully negate the inherent risks associated with less comprehensive medical training when applied more broadly.
This brings us to the nature of collaboration. Dr. Carter, you advocate for how prescribing rights could enhance integrated care. Dr. Petrova, you voiced concerns it might lead to fragmentation. Looking at the current collaborative model between psychologists and psychiatrists, how do you each envision this relationship evolving, for better or worse, if prescribing rights are or are not extended? Dr. Carter, perhaps you could start.
If prescribing rights are extended, I see the collaboration becoming more dynamic and efficient. Psychologists could manage more straightforward medication cases, freeing up psychiatrists to focus on the most complex, treatment-resistant conditions and those with significant medical comorbidities. This would be a more effective use of specialized psychiatric expertise. The collaboration would shift from a referral for all medication to a consultation for complex needs, strengthening the overall system.
My concern, Dr. Hayes, is that if prescribing rights are extended widely, it might inadvertently reduce true collaboration. There could be a tendency for psychologists to manage cases independently that might have previously, and appropriately, been referred for psychiatric consultation, potentially missing subtle complexities. Conversely, if prescribing rights are not extended, I believe we must focus intensely on strengthening the existing collaborative pathways, improving communication, streamlining referrals, and perhaps co-locating services to make the psychologist-psychiatrist partnership more seamless and patient-centered than it often is today. That, to me, is where the effort should be concentrated to improve care without expanding prescriptive authority beyond medical doctors. In closing, my position remains firm. The responsibility of prescribing psychotropic medications should reside with physicians who have undergone comprehensive medical and psychiatric training. This is not a matter of professional protectionism, but of unwavering commitment to patient safety. The complexities of these medications, their interactions, and the critical need to differentiate psychiatric symptoms from underlying medical conditions demand the breadth and depth of a medical education. The potential risks of misdiagnosis, overlooked medical issues, or inadequate management of side effects are too significant to ignore, even with proposed additional training for psychologists. While improving access to mental health care is a goal we all share, this must never come at the expense of the quality and safety of that care. I believe the most prudent and effective path forward is to significantly invest in and strengthen the collaborative care models already in place between psychologists and psychiatrists. Enhancing these partnerships, improving communication, and increasing the availability of psychiatric consultation is the optimal way to ensure patients receive both expert psychological therapy and safe, appropriate medical management.
To conclude, I urge us to view the extension of prescribing rights to appropriately trained psychologists as a vital and progressive step towards addressing our nation's pressing mental health care crisis. The benefits are clear and substantial, significantly improved access to timely medication management, especially for those in underserved areas, and a more integrated, holistic approach to patient care, where therapy and medication are seamlessly coordinated by one professional. This model enhances continuity of care and allows for more responsive adjustments to treatment plans, directly benefiting patients. Concerns about safety and competency are understandable, but they are addressed through rigorous, specialized postdoctoral training in psychopharmacology, coupled with mandatory collaborative protocols with physicians. This is not about replacing psychiatrists, but about augmenting the mental health care workforce with skilled professionals who can meet a specific and growing need safely and effectively. Embracing this change, with the right safeguards, is a forward-thinking solution that can make a tangible difference in the lives of countless individuals struggling to access the comprehensive mental health care they deserve.
Dr. Carter, Dr. Petrova, thank you both for a truly insightful and thorough discussion on this very complex and important issue. It's clear that the question of psychologists prescribing medication involves a careful balancing act between enhancing accessibility, respecting professional expertise, and, above all, ensuring patient safety. We hope this debate has provided our audience with a deeper understanding of the multifaceted arguments involved. Thank